colleagues, it is my pleasure to share with you the observations of a study which in fact was initiated by Thamarao himself as advisor of NHSRC. And I'm really excited. I never thought of it that sometime it would so happen that he would chair a session where we are going to share these observations. In this study, as he initiated, has been conducted in almost, I think now, 6-7 states around the country, and in 3 states I was involved. And in fact, this is the very right opportunity that the evidence which has been collected through these studies, it can be utilized and given as an input to this institute, that how this evidence can be used in influencing policy in the future for HLH. The issues which I am going to touch upon in this presentation is, they're based basically on the premise that the human resource is the most critical component in the health facility. In fact, over 40-50 years, the health systems have struggled hard in doing civil work and equipping the institutes, in making PSCs, in making residences. And it is only for last decade that this awakening has shooted up, accelerated, that the human resource is the most critical component, and the attending to the software is more important rather than the hardware in making the health systems efficient. And because the number of health facilities have increased, particularly the peripheral health facilities in terms of CSCs and PHCs, where the leadership is given by the doctors. At PSCs, largely these are the generalists, and at the CSCs, these are largely specialists. And their personality and their style of functioning determines largely the extent to which a particular institute can be labeled as efficient or productive, or its reputation depends. So, for these two basic premises, the study which was conducted around the country by now in 6-7 states, with the objectives that what are the processes followed by different state governments in recruiting these doctors, in inducting them and in deploying them, because the states are very large. The state from which I come, the state of Rajasthan, is now the largest state in the country with more than 3 lakh square kilometer of the area. Half of it is desert. Population density is low. So, to make health services accessible, equally so in Uttarakhand, where I visited and I saw very difficult health facilities. So, India is a federation of very, very large states, large land areas, and the population density is variable. And when we set up certain standards that are particular for 15,000 or 20,000 or 30,000, depending on tribal area, depending on general area, the health facility will be there, then it is really a challenge for the system at this state level, how to deploy manpower to strike equity. The second things which we observed in these studies on which we lay emphasis was the workforce management issues, the different issues on which I'll touch upon in subsequent slides. Then the third important thing in any system is the compensation or the remuneration or incentives or packages which are given, because they ultimately determine the morale of the person who does the work for that. Then what are the support systems available to these doctors? And lastly, what are the gaps between what is being provided and what people expect? Because health is one such issue, which is a very dynamic issue in terms that with the passage of time, the expectation of people keep on changing. 50 years back, an ordinary patient, if he got an X-ray, he used to feel satisfied. Today, an ordinary urban dweller would want an MRI or a CAT scan to be done when he reaches to the hospital. So, likewise, in almost all fields, whether it is any technology, the expectations keep on changing, and health systems have to work hard to strike a balance for the same. The study of the observations which I am sharing with you is based on these 3 states, the Jharkhand, the Rajasthan and Uttarakhand. And we selected 3 districts each in Jharkhand and Uttarakhand, and in Rajasthan the 4 districts. And our sampling was based basically on the development of the districts in those states, on the Human Development Index. We divided it in 3 groups, the different districts in the state. And we took one district with the highest HDI, Human Development Index, one with the lowest, and one from the medium range to get a feel of what is happening. And in those districts, on a stratified sample, we selected the community health centers, the primary health center, and we interrogated with the generalist, that is medical officer, and a specialist. So we almost interrogated 400 doctors in these 3 states. The first important issue which I wish to share in this context is that do peripheral health facilities have sufficient doctors or not? Like in Rajasthan, there are 1,500. In Jharkhand, there are almost 1,900, and in Uttarakhand, again, more than 1,200 peripheral health facilities are there. But do all these facilities have doctors or not? Just to share with you broadly, in the state of Jharkhand, out of 131 positions in Dumka districts, 95 were filled up. And in Palamu, which has the lowest HDI, only 30 doctors were available out of the 96 positions available. And 29, and the Ranchi, which is the capital of Jharkhand, and which was from a high HDI index of that state, 29 vacancies out of 101 positions. Similarly, in my own state in Rajasthan, there are now 8,162 positions of doctors as of this financial year. And the dynamics which one must understand in this context is that the chief ministers and the political parties in power, every year in their budget announcement, they have their own pressures, and they announce, particularly in context of the education and health, the new positions every year. And in Rajasthan, in the last 2 financial years, 745 and 658 positions were announced. And the government system, the bureaucratic system in this country is that once a political announcement occurs, it takes around 3 to 9 months to get it translated concretely in the practical shape. That because the files move between the administrative department and the finance department, and ultimately positions are sanctioned, and finally when they reach to particular district, it takes a long time. So it is not that overnight the change occurs. And the second important thing is, since systems are large and there are hierarchical systems, so eventually the type of promotions which are to be given to the people also is a big challenge. The point is that in Rajasthan, at the time when we were doing this study, almost close to 3,000 vacancies, out of which 1,490 vacancies were sent to the Public Service Commission. And again, it is a very lethargic process. Sending an indent for the positions to the Public Service Commissions and getting back those people appointed. Well, my experience even at the national level for the CGHS and other Government of India system, when we go to the UPSC as expert, we are told that after we interview those candidates, it takes around 9 months to 2 years for those candidates to reach to the respective position. In the state of Uttarakhand also almost similar observations we found, that half of the positions of journalist and more than that for the specialist were vacant. As he has just shared in his keynote address, the issue is, although of course my focus is on doctors, but as he shared in one of the transparency, that the HRH density determines ultimately the different indicators, the comprehensive indicators, whether it is MR or MMR or IMR or whatever it is. The WHO recommends that the HRH density should be around 25 per 10,000 population. But in our own state, it is a very wide range, from 10 health professionals per 10,000 in Bihar to 38 in Kerala. And eventually when they are related to different outcome indicators, this reflects that what is the meaning of keeping an appropriate and optimum health manpower. Then coming to the issue of the recruitment, some of which I have shared, the other important issue, which is the filling up the vacancies is a consistent challenge. Public Service Commission, I have already talked to you. But the most important thing is the postings and transfers of these doctors. Like 8,000 doctors in the health systems of Rajasthan, or more than 1,200 doctors in the health systems of Uttarakhand for that matter. Deploying them in the peripheral health facilities, and the facilities are at different points. Some stations are very attractive stations. Some stations are very difficult stations. How to keep everyone satisfied is a challenge for both the political master at the helm of affairs as well as the bureaucratic boss who is there. So this is a very dynamic process. Then other important thing which I wish to highlight, which we observed in all these 3 states, is that for last 5 to 10 years, but in particular in this decade, we are passing through a very rapid transition. We have not thought of 20 years back in the health system that the Indian system of medicine would be accepted so easily. But now ISM practitioners are there in almost all facilities under the same roof. And lately, deploying specialists is also receiving attention. Governments everywhere, state governments are making a lot of innovations in terms of attracting the specialists, particularly from those areas where the demand is more. Of course, successes and failures are always there. Then other important issue with the doctors is that when they work in the public systems and when public systems which are directly in interface with the people day in and day night, every minute, every hour, lot of complaints are there, a lot of inquiries are there, and eventually it affects their career as well. So the point is that when these complaints are there and when grievance handling is there, the government has a very complicated and a mysterious system of handling the grievances, which ultimately influence the morale and which ultimately makes most of the doctors wise enough to not to work or to work in a way to keep themselves saved from that. The second important thing is that doctors have a very limited scope for promotion. We found in almost all three states, the average promotion is one in the 30 to 35 years career of the doctors. Unlike the civil services where the slots are marked, the super time scale or saturated scale, whatever they call different scale. But when the positions of doctors are compared with all other services, the promotion avenues are very limited for the doctors. Then coming to the compensation and incentives, the one is in this federal setup, lot of anomalies in the pay structures. Although, of course, largely the value system is that most of the states have now committed that they will keep their professionals and their employees at par with the central government. But when central government announces a increase in DA or a new pay scale or when a new pay commission comes, it takes almost 3 to 6 years or 7 years for state government to follow the suit. And eventually this period of between, because people work in the same city, in the same Bangalore town, half of the government employees might be from the central government, half might be from the state government. And the type of differences which are there in incentives and salaries, they always affect the morale. They are deep in their heart. And eventually this is a very, very tricky and a very complex situation. Then Tamara has already touched on the issue of the difficult area allowances, and he has shown you in different states, the states which are giving it. Then the third thing, it is only through NRHM that this new culture has generated. Otherwise for doctors there was no facility earlier like mobile phones or telephones or any other incentives. And of course the debate on the non-practicing allowance. Because all rural facilities do not have equal scope of practice. But largely the bureaucracy which takes the decision, they assume that all doctors have an equal opportunity for private practice, and eventually somehow some sort of inhibition is there in putting this incentive. Then other important determinants at the peripheral health facility which influence the productivity of doctors is the physical facilities available in the different peripheral facilities. We found in almost 60 to 80% of primary health centers, the 24-hour water supply was not there. What to talk of 24-hour, in most of the PSCs which our teams visited, we found that water has to be stored and that stored water has to be used in the limited time, and most of the staff is very conservative in using that. Then electricity supply is also, particularly in Uttarakhand, we found that almost 60% of the facilities do not have regular, and it is for a very limited, otherwise a lot of power cut is there in those facilities.